Okay, folks, we'll make a start. You're all very welcome. And I do want to particularly pause and say you're particularly welcome because I know how difficult it is to get away and get any CPD these days. So you're all very welcome. So we've got a packed 2 hours, or a very busy 2 hours, that I think will give you a real important overview and insight into virtual wards. Just so you know where you are, this is the RCNI webinar looking at virtual wards. Let me introduce myself before I start rambling on. I'm Richard Hatchett and I'm the chair for the 2-hour event, and I'm the senior nurse editor for RCNI, and historically that's the publishing house of the Royal College of Nursing, but we're kind of a multimedia company now, and we publish 10 journals including Nursing Standard, and we run a series of webinars. We've done quite a few now, and the sort of running order that we do them in seems to work quite well. I particularly want to thank our sponsors for today, HomeLink Healthcare, who without our sponsors we wouldn't be able to put these events on. So I'm particularly grateful to them, and you'll be hearing from Jane Tobin later, who's clinical or Chief Clinical Officer with HomeLink Healthcare. Let me run through the running order. What we're trying to do today is try and get our heads around what makes a good virtual ward and what are the elements that come together, and particularly look at the barriers and prevent ourselves from reinventing the wheel. So whatever your involvement is, whether you're actually running virtual wards or whether you're looking to be involved or you're managing or overseeing, etc., I think there'll be something for you today. Let me go through the housekeeping. And of course, when we were together, I would say to you, the toilets are behind you and the coffee's over there and the fire escapes, but I don't know. So all I can tell you is what the running order is today. And we start always with these webinars with a broad perspective, and we'll be joined by Audrey de Vere-Adama, Assistant Director of Community Transformation for Workforce for NHS England, to give that broader perspective. We've got a couple of case studies which are similar, but there are differences. They're looking at virtual wards from 2 different perspectives. And then we have a panel discussion. And very much, you'll have seen on the literature, it's participatory learning. So you're very welcome in the chat box to put questions in as we go, and also comments. Particularly when we get to the panel discussion, you'll need to help me out because I want to make sure that I'm picking up all of the points that you're making. And sometimes you might not have a question, but a comment is very welcome. So you might sort of say, well, that works well in theory, but what we've found is this, this and this, because people will be looking at the chat box and picking up on those comments, etc. So it really does create a nice virtual ward community, so we can sort of share our learning, because you've got an awful lot of experience in this area. So that's kind of the running order. Let's move on, because they've just given me 5 minutes just to go through those housekeeping points. And great pleasure to welcome Audrey de Vere-Adama, who, as I said, is Assistant Director of Community Transformation Workforce at NHS England. And Audrey is looking at resourcing virtual wards, understanding the core skills and competencies required by nurses. So over to Audrey. Thank you very much.
Thank you, Richard. Good afternoon, everybody. As Richard said, I'm Audrey de Vere-Adama. I work in NHS England as an Assistant Director for Community Transformation Services in the Workforce Directorate. I'm a nurse by background, both adults and children. And I am going to give you a general overview, as Richard said, but I'm going to give you some of the guidances that will support the service implementation. I'll then do a couple of slides on thought-provoking questions to yourself, and then talk about some of the training that is available to support you as nurses and your skill mix team. Thank you. Can I have the next slide, please? And the next one. Thank you. So one of the things we do is we always try to give a definition of virtual wards. And if you've seen this several times, I do apologize, but we do need to go through it. So a virtual ward, the definition is that it's a safe and efficient alternative to NHS bedded ward. And it supports patients who would otherwise be in hospital to receive the acute care and treatment they need in their own homes. It includes preventing avoidable admission into hospital and supporting early discharge as well. Now, there's a whole lot here that I'm not going to read, but basically to say that a virtual ward is not a mechanism intended for enhanced primary care program, chronic disease management, home intravenous or infusion services. I believe that, I'm happy for this slide to be shared with you at the end so that you can see some of the other criteria. Can we move to the next slide, please? Thank you. What the national team did request as a vision for virtual wards is for 2 pathways. And that was the acute respiratory infection pathway and then the frailty pathway. The acute respiratory infection, which we call the ARI pathway, is mostly remote. So it's based on technology-enabled remote monitoring and self-management by the patients with minimal face-to-face provision. And the frailty pathway is mostly face-to-face. And it's based on a blended model of technology-enabled with face-to-face provision. As I go on a bit more, you'd get the understanding on that as well. Next slide, please. So the national ambition when we started the virtual ward, the vision was for 40 to 50 beds per 100,000 in the population across all systems. And that started quite well, but during the winter, as we know, the winter pressures is very difficult and challenging for all services. So a letter went out on winter resilience, asking all ICSs to develop an additional 2,500 virtual ward beds to support the winter. And this is to support additional beds throughout the winter and working towards also increasing the utilization of the vision, the ambition of 40 to 50 beds per 100,000. We aiming that by September 2023, 80% of those virtual wards will actually have utilized their bed capacity. £1 million of funding has been made available through system allocations to increase the urgent and emergency care capacity. And this is being worked through the systems. We are very much aware of the challenges, but I will talk about those of that challenges for recruiting and that, but I'll talk a little bit about that in the next few slides. So can I have the next slide, please? Thank you. Whilst the team is supporting implementation of virtual wards in through the ICSs and the systems, the next 3 things that is being asked of us in NHSA is to ensure there's stability. So to stabilize the focus on virtual wards, with system being asked to build on what they've already done. This is the 2,500. So building capacity and occupancy. Standardized virtual wards across ICSs, because we're very much aware also that there were some virtual wards in the COVID season, pre-COVID, that is still running. So we want to be able to standardize all the virtual ward offer.
While we're just doing that, folks, and hopefully we'll get Audrey back. Jane is going to look at one of our case studies and is looking at the nurse's role in the setup and delivery of a virtual ward. And Jane is clinical, sorry, we keep wanting to say clinical, chief clinical
Chief,
officer.
I don't mind. Clinical.
Okay, we'll get it the right way around for HomeLink Healthcare. So I'll hand over to Jane. Thank you very much for stepping in a little bit early, Jane.
That's okay. So welcome, everybody. I'm Jane, as Richard said, and I'm Chief Clinical Officer for HomeLink Healthcare. So my background is nursing. I'm a community nurse by trade from a very long time ago and a district nurse. So for me, this is really exciting, being able to work in this sort of environment, that space between hospital and the community. My actual role in HomeLink Healthcare is to make sure that all our services are safe and that those services that we are delivering to patients, you know, are of high standard and that nurses and patients are safe. So can I have the next slide, please? And the next one. Thank you. So just moving on from what we're going to talk about today. So very briefly, I'm going to touch on HomeLink Healthcare, who we are, what we do, and how we've got to where we are today. And then look at the opportunities for nurses in the design of a virtual ward and then in the delivery. And then we will just see a video which is going to demonstrate, I hope, nicely that journey for that patient from the ward through into the home. So next slide, please. So yes, we are Home-Linked Healthcare. We've been working since 2016 in hospital at home type services. We're dedicated very much to providing safe, efficient care at home. Our CEO is a nurse, and we've got a doctor on the board. So it's a clinically owned and clinically led organisation. We're very, I'd like to say, NHS-like, so we focus very much on working with the NHS and making sure that we meet the same exacting standards in the NHS, and that people have a very safe transition to and from hospital. We are looking at improving patient flow, so our aim is always to get patients out of hospital. And in the last 12 months, we've done sort of 44,000 visits, and there's over 2,400 patients, which equates to about 47,000 bed days saved. So there is a real sort of value in these sorts of services, in that sort of space between hospital and community, to allow people to settle almost before they move on to the next stage. We've got a highly skilled multidisciplinary workforce, and we've, to date anyway, got sort of 100% NHS partner satisfaction. So you can see it's a real passion of ours, and we really do want to make sure that all our patients and our staff are safe. So I hopefully will take you through the journey of how we've made that happen. So can I have the next slide, please? So the next slide, this slide is really just looking at the sorts of pathways that we have been able to offer. Not all of them true virtual wards in the context of what we're talking about today. They're all face-to-face visits, and some have remote monitoring. So we have the discharge to assess model, where patients are coming out, frail elderly mainly, and they're being assessed at home. And this was particularly through COVID, and some areas this has been continued. So those assessments are taking place at home. For the nurses, then the opportunities there are really those holistic assessments, those risk assessments, making sure those patients are really safe and confident in that sort of sometimes quite scary time when they do come home and they realise they can't do the things they thought they could do when they were sitting in their hospital bed. So that, and nurses play a really key part in that. Admission avoidance again. So I'd like to think, I mean, I have run true admission avoidance models in the past, but what we do is we really do prevent those patients coming home and then falling in those last sort of first 48 hours, which is a really crucial time for people. We've got pathways in one of the hospitals that's linking very closely with ED, so we will take them out, they'll go in and they'll come out quite quickly. The reablement pathway is one that is physio-led, and patients are coming home and having their clinical outcomes measured. They're on a pathway, and generally those patients do improve and go back into the service, into community care a lot better, and more able to live independently. High acute nursing care, again, IVs, PICC lines, respiratory patients. We've got those patients, and then we have the virtual ward, which we've got with Norfolk and Norwich Hospital. We're going to hear a bit more about that today, but we've also got a video just to show how that really works. So that's the true sense of the virtual ward, wherein the wearables being monitored, coming home, and that real communication between the hospital and Home-Link, as we sort of provide that face-to-face clinical care at home. So can I have the next slide, please? So with the opportunities for nursing in the setup and developmental of virtual ward, I think we said that nurses are involved at all stages of that virtual ward journey and have an important part to play on the patient journey. So what skills do we really need for people that are coming out and working in these sorts of settings? So I think people have to have resilience. I think people have to have common sense, a lot of knowledge. They have to be able to think on their feet sometimes and have that accountability for the work that they're doing. And they're the sort of skills and that compassion and empathy that we want from people. We can train people, so it's that space, as I said before, between hospital and community. So people that haven't necessarily got that experience in the community, we have quite a robust lone working training at the very beginning, so that they feel safe and confident to go out. They've got supervision, etc. So it's to allow people's patients and nurses to feel safe. They co-design the services. They're very involved in looking at the pathways, what sorts of pathways we can do. It's wrapped around a clinical leadership piece and governance. So with that, we're looking very much about how safe patients are, what the governance framework for the trust is, or for the NHS is. We have our own governance framework. We use an incident reporting system, so there's that wraparound care. We are open and transparent. That's what we want to be. So it is about reporting on all incidents, examining them together, having service reviews and looking how we can improve the service. And nurses are really key to that. They're the ears and eyes out there. They're either managing or delivering on the service, and they feed back constantly as to how we can improve things, or what maybe, you know, what we can do to make things better for that patient experience. We also at this point have an ops manual, so we work on a almost SOP or a blueprint. So this is a operations manual that gives us really all the telephone numbers, the escalation pathways, how we can contact people. So the nurses feel very confident when they're out there. It's been agreed by the trust as to how we want these pathways to work. And that's part of that sort of setting up, but also that is something that, you know, the nurses are very, very key in to developing that and changing it if it doesn't work. Moving on to the pathways, then the pathways are developed by clinical colleagues. We have obviously got a sort of a suite of pathways, but all of them are unique to the organisation we're working with. So they will be different in different places. There'll be different escalation points. There'll be different people that we contact, and that is the beauty of setting it up with the trust. So it is something that you've worked on together, so it's a joint sort of adventure and joint pathway and a joint journey for us both. So also within that, we look at the KPIs and the reporting and evaluate the service. So again, at the service review meetings, we start looking at those measures. Have we got them right? Is there something we can change? Nurses will report back as well, you know, in terms of whether it's working for them, going out and delivering the service, and also the clinical leads. So that's very much a joint service review with key people from the organisation we're working with. Quality and safety for both our staff and patients is really key. So we look, I mentioned the lone working at the beginning, so people must feel confident to be out there because they are driving around. We have a scheduling system, so that allows us to schedule people's journeys and their visits. Generally, our nurses spend about 45 minutes to an hour, but that's because we want to give them real quality time with those patients, and they have about 5 patients on a 7-hour shift. Our service covers from 7:30 in the morning to 10:30, 11 at night. And those patients and those visits are scheduled in a way that those are manageable visits and times. And obviously, if something happens, somebody falls, there's an emergency, then those times can be adjusted. And staff feel very much involved in sort of how that can be managed for them. We also do, obviously, I talked about the risk assessments earlier, so all the patients that come out have risk assessments, outcome measures, and a holistic assessment. So, and we have live electronic records which we can share with the trust, and we also report into the trust zone system. So, if there is a situation, you know, we can use our remote tablets that people have got to take pictures and to discuss. We have done video conferencing at a patient's house. So I think the key thing is we want to say that patients always feel safe. particularly in that transition point coming out of hospital, and our nurses and our healthcare support workers and our physios and the people that work with us feel safe as well. And I think the last point just here is we try and start small. We have a hypercare period where everybody's having weekly calls just to make sure the service is running safely, to make sure that the numbers are there, because sometimes maybe the numbers that we've suggested or we've worked on together just aren't there. So how can we get more patients out? Are we getting the right sort of patients? Have we got the pathways right? And quite often we might start on one pathway, and then later on it might be, actually, could we have a virtual ward as well? Could we start looking at a different pathway? So it's all about test learning and growing along the way. Can I have the next slide, please? So what real opportunities? I touched on some of those opportunities, the skills that we're looking for. So all our nurses that come and work for us have got at least 3 years experience, as have our healthcare support workers and physios. So we want people to have got quite a grounded experience before they do come out there. And I know, Audrey touched on the challenges of recruitment. So I do know we will be looking at other ways, apprenticeships and things like that with trusts and with universities, etc. But at the moment we're saying 3 years experience, and we can teach some of those skills. So we want those values. We want people that really want to be doing the job and enjoy the job they're doing and give good quality care. So people do come to us with community experience, and sometimes they haven't necessarily got so much, perhaps with IV experience or taking bloods or something. And likewise, people that have worked in a hospital sometimes find it a bit frightening to work in that community space. So I think what we provide is a safe space. They can work in both community and the hospital setting, and it's a safe sort of environment, and people do really love the work that they're doing. In terms of leadership then, so our nurses are very much at the forefront of the leadership roles. We've got clinical and operational leads who we see very much as the people holding the ring on that service. So they will be the people that get the data together for the service review meeting, review the records, review the encounters, and make sure that the team is running smoothly and that the staff are supported. They'll be the people that are really trying to find out how we got the patients, liaising with the consultants, maybe in the hospital, trying to find out if there's different pathways, different patients that we can have. Typically a team would be a clinical and operational lead, an assistant lead, and then probably a discharge coordinator whose job would be going around looking for and identifying patients that could come out onto the service. Assessment and delivering care. So this is our delivery arm for the patients that are out in the community. And as I said before, they have assessments when they first come out. So there'll be and really, ongoing ears and eyes every day. We've got electronic records that can be viewed from the people that are on call, plus the people when they're there, they do it electronically on their iPad. We've got a range of pathways and a range of skills that are required for nurses to carry out. So they may include IV antibiotics, they may include complex wound care. We do a lot of VAC care. We do take bloods, and some of our healthcare support workers go out and take bloods. Obviously if they're on PICC lines, etc. Plus just looking after people on that frailty and respiratory pathway, really, and making sure that they're safe. But a big thing is the communication and the feeding back, and that is crucial, that communication between both the hospital and us, really. And in terms of the virtual ward, and you'll see it in a minute in the video, that communication happens every day. So every day there is they have a meeting every day. They run through the patients, they make sure the patients are safe, they identify patients that may be escalations, required, that may be deteriorating before they even know they're being deteriorating, and also, you know, that sort of wound care, reporting back on how the patients are, and building, I think for that it's very much about, as much as it is for the patient, but those carers, the wife, the partner, the next of kin, who are initially really anxious about patients sometimes coming home because they feel that they might not be able to cope. And a lot of it is supporting those, you know, the whole family in those situations. Case management is another key point. We liaise with GPs and the wider MDT, obviously 111, plus ongoing care providers, so both in the early supported discharge model, but also in the virtual ward. Sometimes they come out with care packages and they will be moving on to longer term care, and it is making sure that those that transfer is seamless and safe. And plus, quite often they do come out with one set of needs, but actually by the time they move on, they might have had those care needs reduced. And then overall, wrapping around with the virtual ward particularly, you've got the virtual monitoring, and you'll see in a minute how the wearables play a really key part in keeping those patients safe. And I'm sure you'll hear from Mike later, but you know, the wearables allow patients to come home and be monitored continuously. We've got to see them. There's a team of nurses in the trust that are monitoring that and liaising with the home link team, you know, if those patients need a visit, and they might go out, might be struggling with the equipment, or it might be that, you know, they are getting poorly, or they do need escalating. So that is a really crucial bit about keeping those patients safe and feeling, you know, that they are being looked after and being monitored. We've also got 24/7 clinical on-call service, which supports all our virtual wards. So we have a clinical member of our team on call, so that nurses and patients can contact us at any time of the day or night. Okay, can we have the video, please? So we're moving on to the video, which I hope demonstrates what I've been saying.
Okay, we're just going to see a patient to get her consent and see if she wants to come on the virtual ward before her operation in a couple of days. Knock, knock. Hello, my name's Claire. I'm one of the nurses on the virtual ward. I've just come to give you some kit and explain what the virtual ward actually is. The kit in here will monitor your heart rate, your oxygen levels, your respiratory rate, all that kind of thing, and your skin temperature as well, so we can make sure that you're not becoming more unwell before you come in for your operation. Okay. Yep. And there's a blood pressure kit in here as well. When it is on, we'll give them a couple of different options. It will say set up or calibrate. They press set up and it will step by step tell them exactly how to set the kit up. But we're also always on the end of the phone. They plug in the modem and that just plugs straight into the mains. Doesn't need internet connection. It gets its own internet connection. That's fine. Yep. What the patient has to do is line up the arrows, click it in, and then pop it on, and that will give us the heart rate, oxygen levels, respiratory rate, skin temperature, and movement. And we get the information every 3 minutes. So, with a lot of our patients, we see them deteriorate before they feel ill, so their heart rate will go up or their skin temperature will go up. The way the virtual ward works really is two-way communication. We can always get hold of them through the tablet, but in the same way, if they wake up at 3 o'clock in the morning and aren't feeling very well, they can get hold of us as well.
163/98. Hello.
Good morning. How was your night?
Yeah, it's good. Not bad. Slept well.
Your blood pressure is still
high. Yeah.
Are you feeling any symptoms from your blood pressure being elevated at all?
Not really. No.
If you could do a repeat blood pressure for me around lunchtime, I'd really appreciate it.
I've got a cat on my lap now.
Oh, have you?
Yeah, I'll show you, shall I?
I see. Yeah, do. Swing it again. Oh.
You've got really good staff You know, if you have staff that are just doing it for the money, I don't think it's the same. The impression I get is they're doing it because they care. If that makes sense.
No, I'd had a stroke. I had a headache last Thursday. My doctor came home from work on a Friday and said, your left side of your face is drooped. We're going to hospital. I think you're having a stroke. So that was it.
Rose rang us and said Leslie had to have this when he arrived, when it came.
2 nights, last Friday and last Saturday. Never having been in hospital before, overnight, it's just a big shock. And they told me about this sometime on Saturday, that I'd be going home to do this virtual ward on the Sunday.
My first reaction was he's coming home. However he comes home, so long as he comes home. But obviously that he would be safe, because in the back of your mind you're thinking, well, what if Leslie has another attack or something like that?
Because the information going back to the hospital is instant. That all helps the security, the feeling of security.
It takes 30 minutes to charge it up, and I normally do that when he's in the shower. Yeah. So no, it's brilliant. Yeah, it's very, very, very easy to put on and off. And if wasn't anybody here to help Leslie, you know, I'm sure that someone could do it on their own. Because it's remote and we're allowed to be with Leslie, I can ask questions as well, and the family if they've got any questions. So it's brilliant.
The hospital knows what you're up to, what's going on with your body 24 hours a day. There's nothing to worry about. Just follow the instructions and just do it. I thoroughly recommend it. It's great being at home.
So I'm a registered nurse. Today we're going to see patient Kenneth Larkins. We're going to go in, meet them for the first time, and get their observations, some blood work, and some wound care. Good morning.
Good morning.
My name's Janae. I'm your nurse. You must be Kenneth.
I'm Kenneth.
And you must be Rose.
Yes.
It's nice to meet you both.
Thank you.
How's your foot been feeling?
Well, it's all right. Yeah, I think it hasn't been in pain or anything.
First thing we'll do is we'll take some blood, if that's okay with you.
What is this tested for?
So they're going to make sure there's no infection markers, and they'll be checking all your blood counts. And they'll be doing this twice a week, and the virtual ward will be keeping up with the blood results. And if at any point you need antibiotics, they'll know pretty much right away.
You feel relaxed in your own home having the same treatment done.
Yes.
So, and you know, and these nurses are so
So skilled.
so accomplished.
Yes.
You just feel safe.
Well, leave here with a baby. Go if you're not careful. Lacey said you might have trouble right in this area. If it's going to leak, it's probably going to be right here. So if you do notice it,
Will it come up on the machine then?
yeah, it'll
Say.
it'll go kind of beep boop, and it'll tell you. I love this job. It's the best job I've ever had as a nurse, definitely.
Okay, can I have the next slide, please? Okay, so we've just heard from Janae about that. So that was the home-linked nurse that was doing the clinical angle of going to see the patient, doing the vac pump, taking the bloods. But obviously, it's the Norfolk and Norwich staff that are monitoring and running the virtual ward. So that shows that real good communication between us and how that sort of patient journey can be really enhanced and improved. So in summary, then, we know 14,000 beds are occupied by patients that are able to leave the hospital. We know that the ambulances call out is going up by 1/3. We know that we have to find different solutions. We know we have to increase capacity and resilience. So virtual wards are really, for me, that discharge planning home starts as soon as that patient gets into hospital, and this is in a way a bit of a no-brainer. There is a lot of patients that could come home, and that's the sort of space that we can really offer a difference and improve patients' journey and care. We know then that patients can receive the same level of care and support as they would in hospital in the comfort of their own home. We know that patients really do appreciate those sorts of real warm visits and face-to-face visits, as well as the remote care. Nurses are at the heart of the setup and the development of the service, and how they develop that service is really key to review and evaluate as it goes along. We know that they can be involved in all stages of the patient's journey, and that's an opportunity for nurses to really spend quality time with their patients, provide that best care possible. And I think that comes back in our feedback. And I'm not saying it's exclusive to us, but it is what we have found, that nurses really do appreciate having that real time with patients, to give really good, high quality care. We know that there's improved patient outcomes and improved patient experience, and we know, our staff are happy in the work that we do. So that's really all I've got sort of to talk from today. Can I have the next slide, please? Just really to finish off, so if you haven't got any further want any further information, want to contact us, then there's our contact details, and thank you for listening.
Thanks very much, Jane. You can probably guess as you're talking, the questions are popping in, so we've got a little bit of time. I mean, I think for everybody, I'm not going to get through all of these questions, but Jane's put some contact details there, and I know she's more than happy to answer 435 people's questions.
Oh gosh.
But, no, don't worry, Jane. Just some different ones that are popping up. Is it a useful environment for students?
So I would definitely say yes, it is a useful environment for students. There's a little bit of work we've still got to do about working that through, but I think where certainly I've worked before where we have had students out working with us. So yes, absolutely. And it's also a space, so it isn't sort of, we're not trying to be district nurses, community nurses. We're not doing that long-term care, but it is giving them a flavour, and I think seeing that patient journey all the way through, from when they're admitted to when they come home, is just so important for people when they're caring for patients.
And a question about where does the responsibility lie? Is it the medical doctors in the hospital, or is it in the GP?
No, sorry, I should have said that a little bit more in the accountability bit. So the responsibility, depending on the model, sits with the consultant in the hospital, and they are responsible for the patients. On the discharge to assess model, then it would be the GP and the community care, because those patients are actually discharged. But on the virtual ward model, then it would sit with the consultant in the hospital. So it is the consultant that refers onto the ward. That's part of our role, that we work through those referrals, and then they will have that clinical accountability until they leave the virtual ward.
Great. I'm also grateful to Michael, who's answering some of those questions for me. I mean, the experience that staff require, I think you mentioned 3 years, and somebody was commenting, what experience do you want people to have? Is that in the community? Is that in the hospital? Is that both? Or is it individual?
It can be either, as I mentioned before. So we do have some nurses that come to us directly from hospital that have never had community, but they do need to have those, qualities of not panicking, because you don't always you don't always know the situation you're going to be facing. So we can train people, we can support people, we can give people supervision. We do like some community experience by just because we find that people that have worked in the community understand how the community works a little bit more, but it's not exclusive. So it is that 3 years. I do think that we do at the moment ask for people to have that sort of, to have that sort of core skills and background behind them, really, I think, before they come out.
Also, there's certain patients who will never, I presume, work with the virtual ward. I'm thinking of my parents, actually, who are up in Norfolk, and their local is Norfolk and Norwich, who technologically, is there a worry of some people being left behind with as we move forward in technology? I suppose that the step there would be that you find out what their support network is.
Yes, so with that, so I might be able to talk about this a little bit later, but when they agree to come on to the virtual ward, that assessment's been done by the virtual ward, and then we would do that assessment again before they came home. So if they were very, very unsuitable and frightened and not able to manage all that technology, then possibly, you know, it might be that we go and visit more often. It might be, you know, we would look at those patients on a case-by-case basis, I think. But the wearables are very simple, much more simple than perhaps it looked in the box. But it is a sort of device that goes on the arm, and then they are monitored, you know, by the virtual ward in the Norfolk and Norwich Hospital. So if we can support them to have that, then we would.
A question about deteriorating patients. How can urgent messages be communicated using virtual wards?
So again, that would be in that sort of operational manual and blueprint thing that we put together at the very beginning with pathways. So if patients do need to go into hospital, or just the situation is escalated, each patient has got a sort of care plan, and we've got contact details, contact numbers, and what to do in an emergency and who to contact. And if it is the virtual ward, then it would be we can contact them all night and equally either way. So but that would be covered off in that sort of operational manual that's been put together by both the trust and ourselves in terms of how to manage this. If it's a community-based patient, then it would be 111 or 999 if it was a real emergency.
Just some practical questions about cleaning the equipment between patients and that type of thing.
So we all wear PPE, which is disposed of in the home. People have cleaning equipment, cleaning wipes, etc. So if there is equipment that needs to be cleaned, then that would be done before they moved on to the next patient. Then we use, in terms of the hospitals, etc. Again, clinical waste, etc. like that. That would all be agreed in that pathway.
Great. I'm also just letting everybody know that, as I've said, that Michael is answering a lot of these questions in the chat box, folks. So if you can pop that on your screen right on the far right, you'll be able to see a lot of questions that we can't get through with Jane. I think that's, I'm just having a look, folks, so we don't miss anybody out. A question that came right at the beginning is the interface between HomeLink and the NHS, and how that works. I suppose how the company fits with the NHS when the NHS is used, when HomeLink, because you know a little bit more about the organisation itself and how it sort of supports.
Okay, so as I said, we're a clinically led organisation. We've all trained in the NHS and worked in the NHS, and that's what our real focus is on. So it is about what we want to do is help improve that patient flow, patient journey, patient experience with the NHS. So that is how we fit with them. We're commissioned, and we're commissioned for a number of visits. Usually that's a unit we work in, so it might be 200 visits, it might be 250 visits, it might be 150 visits, depending on sometimes it is the budget, sometimes it is, in terms of what they're trying to achieve from the hospital and where their blocks are. And then we work, having commissioned us, then it is a very joint approach into, we have a kick-off meeting, we all work together, we have work stream leads, somebody from the trust, somebody from ourselves, and we work through all the pillars, if you like, before we get to that sign-off, so that the service is safe, and it is, as I said, constantly reviewed. But in terms of, we're not trying to sort of come in and go, this is it, take it or leave it. It's very much working with individual organisations to get the service that they want.
Great, that's great. Perfect timing as well, Jane. That's fantastic. But your contact details are there if a few people want to make contact. Thanks very much, folks, and also thank you for all those comments, because it works very well, as I said at the beginning. I just wanted to mention, because I forgot to mention, that Baywater Healthcare are also sponsoring this event, so apologies to our colleagues there. I should have mentioned that at the beginning. We're going to move straight on to our second case study. So Sophie, you're just going to leap in here, and it's good to welcome Sophie Leleno, who is contract manager at Baywater Healthcare, and she's looking at lessons learned, slightly retrospective there, resources, communications, and patient and clinician impact. So I'll hand over to you, Sophie. Thanks very much.
Thanks, Richard. Thank you very much for allowing us to present in part 2 of the RCNI webinar. As Richard said, my name's Sophie Alano. I'm the contracts manager for Baywater Healthcare. My colleague Jenny Hall, who's our clinical and commercial director, is also joining me today. Jenny will be involved in the panel Q&A, which is a little bit later on. Next slide, please. So as Richard said, we're going to have a look at the lessons learnt with regards to the Gloucestershire COVID-19 virtual ward, which we started in November 2020 and is still running today. Part 1, we looked at obviously how we set it up, implementation, execution. So we just wanted to touch base today on what we did with regards to lessons learnt, both from clinicians and patients, but also challenges that we've faced as a provider. We're going to touch base on some of those when you're putting together your business plans or looking at starting up your virtual wards, some things for you to take into consideration. And I have got my contact details at the end. So if you've got any questions or you would like some more information on how to do it, if you're just starting out, then please do feel free to contact me. Next slide, please. So just a little bit about Baywater Healthcare. So we are a specialist provider of in-home respiratory services, and we look after around 40,000 patients here in the UK. We have over around 1 million patient interactions per annum. Just down the right hand side, you'll see just some of the accreditations that we hold, which you would expect from any in-home provider. And our services run 365 days a year, 24/7. We're obviously looking at virtual wards today. This list is not exhaustive. These are just some of the therapies that we cover in home for patients. Next slide, please. So just to recap, I'm not sure whether everybody would have seen part 1, where we talked about how we set up the COVID virtual ward. Just to recap on some of the bits, just to make sure that everybody understands sort of what we're talking about. So the objectives of the COVID-19 virtual ward was to look for early intervention for those patients with silent hypoxia, just to ensure that they received the correct treatment and support. We utilised reporting tools within the NHS, which obviously identified patients who were positive COVID. And we had inclusive access for all integrated care services. So a bit like Jane talked about before, including out of hours, emergency discharge, primary care, rapid response, 111. We ensured that we covered county-wide integrated access to make sure that everybody was inclusive in the service. We work collaboratively with all the teams, just to make sure, obviously, as everybody says before, it's safe, it's easy, it is quick for patients to be onboarded to the service, and that everybody was trained up to the expectation that they needed. So not all clinicians obviously need every part of access to the system. So we ensured that we spent quite a bit of time on user roles access to make sure that that clinician had the right access with the right levels. Again, that helps to reduce time of the clinical team trying to monitor these patients from afar. Next slide, please. So the service overview, we've seen over 7,300 patients through the ward now. As I mentioned before, this is from November 2020. All patients were obviously COVID positive, and they're being monitored by a centralised hub, GDoc, over in Gloucestershire. Obviously, they were on the service for 14 days to start with, which was reduced later down the lines by the government to 10 days. They were referred to the service via a simple referral form, or what we call GP up a mountain. So if nobody could get to a referral form or a laptop to fill it in, then you give us a call, and all calls are obviously recorded, and we take that information from that clinician over the telephone. Baywater Healthcare, they monitored the non-compliance alerts. So a lot of noise obviously in the system is patients not entering data at the right time. This obviously isn't clinical. Most of the time they just needed a phone call to ask why they'd not taken them, or they were having technical difficulties. So Baywater Healthcare dealt with all that noise in the system to help support the clinical teams to make sure that their focus was as literally on monitoring those patients who needed them. And how the service worked, just briefly, so the patients were emailed a link to their own technologies, be it smartphone or laptop or tablet, with a login and password, and our long-term conditions team over at Baywater Healthcare onboarded that patient. So it took around 20 minutes to talk them through what they needed to do, make sure they'd got the correct peripherals that they needed, and could get in and easy access to the system and any questions that they had. Next slide, please. So just some of the lessons learnt that we worked through really with the team over at Gloucestershire. As I mentioned, patients were obviously taking readings twice daily, and for such a big cohort of patients, when obviously the pandemic first set out, we found that this was probably too much. Not all of the patients required that twice daily monitoring, and there was a lot of non-compliance alerts in the system due to that reason. So we reworked with the team, and we decreased that to morning readings. Obviously, some patients who required the two-time monitoring in one day, that they stayed the same, but there was the majority of the patients that were seen through the ward just entered readings in a morning. We adjusted obviously the thresholds to fit what was normal for that patient. So we were obviously set guidelines, as everybody was, by the government as to what that threshold was going to be for patients potentially with silent hypoxia. But we found as we were working through this that didn't fit all patients. So the learning disability patients that we monitored through the system, they standardised their SpO2 a lot lower, and that was normal for them. So they were alerting all the time, but didn't necessarily need clinical intervention. So one of the lessons that we learned, obviously, and changed as we were going along, was to make sure that those readings were set for those specific patients individually, and that not everybody would obviously fit into the guidelines. We've got obviously one system that does fit all ranges of patients, but obviously there was bits that needed tweaking. So we were all faced with these challenges as we saw them. So there was language barriers where patients' first language wasn't English, and we'd got questionnaires out there in multiple languages to make sure that they were readily available for patients that needed them. As mentioned before, patients with technology difficulty. So we did have equipment that was delivered, tablets, smartphones. However, it didn't fit everybody, so we would ring those patients for their readings over the phone. They'd still have their peripherals that were delivered at home, but if they couldn't physically use a tablet or a smartphone, again, we looked at the patient's circle of care to make sure that they'd got support in home as well. So we adapted processes along the way. We made sure that we were obviously still covering what was needed, but different levels of monitoring as we were sort of pushed with this challenge, as everybody was. We made sure that we adapted, and the team over at Baywater Healthcare and over at Gloucestershire worked collaboratively through these changes and challenges that we were faced. One of the other ones was the postal issues of SpO2 oximeters. So as we can all remember, the postal services got hit quite hard, and we had to quickly adapt to make sure that these patients who needed these pulse oximeters to be monitored at home got them within a set period of time. So we used a volunteer group, and we had drop-in hubs to collect pulse oximeters from, and we had our technicians, our Baywater Healthcare technicians, doing doorstep drops to make sure that the equipment was there and readily available for these patients. We also put stocks at GPs and hospitals to make sure that if there was a carer or somebody that was in the household, or even a neighbour, could pop over and collect these for a patient, to make sure that they'd got everything for when they were discharged. We also obviously paid extra for a guaranteed next day delivery service to make sure that we'd covered all angles to make sure that the service was very inclusive and could fit anybody. Next slide, please. We obviously, like everybody, had to adapt to the government changes in the guidelines regarding the monitoring of oxygen saturations. As mentioned before, we work round the clock, all of our teams do, so we were able to change these thresholds, parameters, question trees, make sure that everything was aligned to what we were supposed to be doing. At one point, we had over 340 patients on the ward at one time. So due to obviously the size of Baywater Healthcare, we were able to scale up and down with staff depending on how many patients were active at any one point. It wasn't really a challenge for us. It was more just an expectation when you're looking to do your business plans or you're looking to have a look at setting up a virtual ward, just to make sure that you are putting enough time in to make sure that you can cover where a scale up or scale down is needed. And we utilise text messaging to these patients as well for missed readings. What we found was when you phone patients, they don't necessarily always answer. They might not be near the phone, or they don't answer unknown calls, etc. So their preferred method was for us to text them to say, is everything okay? Could you please enter your data for today? And we found that it got about a 90% hit rate of patients then logging into either their own technology or Baywater own technology to answer their questions. So preferred method of contact, as we saw, was text messaging. Next slide, please. So just from a provider's perspective, when you're looking at setting up a virtual ward, or you feel that a virtual ward is needed, some points here that we talked about as a team, both with Gloucestershire and internally at Baywater Healthcare. We need to know roughly or what you feel will be the number of beds that you're going to use in that virtual ward, and the anticipated demand that you think is going to go through there at any one point. It needs to include the number of days that you're going to look at monitoring. So is that going to be 7 days? Is it going to be 14 days? Is it going to flex? Obviously, we could support you in writing specifications and service level agreements that you could have a model that's a two-tier approach. And who's going to monitor them? Do you want Baywater Healthcare or your provider to monitor those technical alerts and you have your own clinical monitoring team, or are you expecting the provider to clinically monitor that as well? It's really hard for anybody to predict what those costs are obviously going to be. So as much information as you can actually give in your specifications and service level agreements supports the end person, be it the provider or whoever it is that you're setting up the virtual ward with, to cost that effectively. Integration. So obviously integration is really important. The exchange of physiological and vital sign data into the system for the NHS to access. Baywater Healthcare has an open API, but it requires the NHS to allow us access into that system. So we obviously have our own dedicated IT team who then work with somebody within the NHS to support that transition of that data. And what data do you want to put into the system? Is it just your vital sign data? Is it the questionnaire data? It's really important when you're looking to set up a virtual ward to have a look at what actually is needed and how much of information is needed to go into the NHS system. Obviously, everybody is allowed access who is clinically monitoring those patients, and you can see all that data in the separate system. But what do you want to feed through? So that's just another point to think about when you're again looking at your proposals. A range of peripherals and wearables. A lot of people obviously put in there that they want every peripheral and every wearable for every patient. Well, that's a huge cost to the NHS. It really needs to be thought about. What is it you're looking at? What is it you're wanting to monitor? Not every patient would require every peripheral. And a wearable, is it continuous monitoring? Is that needed? Like I said, we can support you if anybody has any questions or queries around where you start with all this. There's lots of questions and things to obviously consider, and Baywater Healthcare are very, very willing to support you in trying to build some of these specifications or answer some of these questions, or help you give you some of the questions that we feel that you might need to answer. Use of patient-owned devices. So we've already touched on this. It's a lot more cost effective for the NHS for the patients to be using their own devices at home, which we have obviously found with the COVID virtual ward over at Gloucestershire. The split of patient-owned equipment against the provider giving equipment out is obviously everybody has to recover their costs of equipment. So it is really important when you're looking at referring these patients in. The first question you ask them is, do you have a smartphone, or are you able to get onto the internet? Have you got a laptop at home? Again, you'd see a lot more patients through the virtual ward with them using their own equipment. Also, they're more familiar with it. They know what they're doing. The risk of them not entering data is obviously a lot more lower than what it would be if they were to be given equipment that might just cause them to be a bit more anxious. Next slide, please. So just in summary, the Gloucestershire COVID virtual ward, it was easy to use for both patients and clinicians. We did reduce hospital beds and still are, where they weren't clinically needed. We implemented a new safe service within a 2-week turnaround. And we overcame our challenges by working together. We had an open communication all the way through, and still do now. We've made some great relationships with the ICB and some of the clinical leads over in Gloucestershire. And I think that's probably key, making sure that your virtual ward is worked through collaboratively, and everybody involved has a good communication panel. And we ensured we gathered feedback as well from patients and clinicians, both to prove the concept, but also to innovate it and to see where the challenges were. Obviously, we put in place the text messaging instead of phone calls to patients, which came back on patient feedback. We had a look at the one system fits all with Gloucestershire to make sure that we were inclusive, that equipment was available, and where patients couldn't use equipment, we provided a phone service. And again, some of the barriers for patients, the language barriers, technology barriers, communication barriers, we worked through all those as we were going, as we were still providing the service. Next slide, please. So my contact details are obviously on there, and there's a QR code box that you can obviously scan into. There's lots of information on our website, baywaterhealthcare.co.uk, and I'm happy to take any questions or queries, or even just a general chit chat with anybody, any clinician or any commissioner or patient, if needs be, that has queries around the virtual ward, how to set it up, how to manage it, where to start even. But thank you very much for allowing us the opportunity to present again. It's been lovely. So back over to you. Thank you, Richard.
Lovely, Sophie. You rattled through that. That was wonderful. Thank you very much. There's been lots of questions in the boxes, and I noticed Jenny has very kindly answered some of those. So at some point, Sophie, you might want to pop into the chat room to answer some of those. People are talking about your readmission rates, working with care of the elderly homes and those sorts of things, and people, I'm noticing people who are non-compliant, what we do with those when they're we find they're in the virtual ward but they can't work with the technology. Now you're staying with us in the panel discussion, I think, Sophie, aren't you?
Yes, please.
So we can pick up some of those depending on the panel discussion. Sometimes bubbles along, sometimes goes a little slow, but the audience today, and there's 410 people on, they're popping questions everywhere, so we can pick up some of those, I'm sure, as we go through. What we're going to do, folks, is we're going to take a 5-minute comfort break, and then the panel discussion, as you probably know from your programme, is looking at overcoming barriers, excuse me, barriers to delivery, and focusing those around top tips. And we've got a lot of people on the panel, so we'll take a short break now, just for 5 minutes. Then we'll come back and we'll pick up some of those points that are coming into the question box. But my colleagues, I'm sure, if they've got 5 minutes, can answer some of those questions in the chat as well, if we don't get round to those in the panel discussion. So I'll see you back here in 5 minutes, and then we'll introduce the panel discussion and bring a lot of what we're talking about together. So thank you very much. Grab a very quick coffee. Okay, folks, we'll move on. Hope you grabbed a cup of coffee. I've just had my coffee machine explode, so I'm feeling, feeling in the days when we all used to get together, you go and some nice person would pour you a cup of coffee, but virtually you have to do it yourself, and it doesn't always work, but never mind. We're moving on to the panel discussion now, and what we've been asked to look at, particularly, though we'll take the questions that are coming in as well on the Q&A, as we were saying, is looking at overcoming barriers to delivery and getting some top tips for you. for, it says nurses and managers, for all of us really, on the practicalities of providing care within a virtual ward. And I'm sort of cross-referencing to what's on my screen. Karen's here. Karen Anderson is Head of Children's Services for the Dudley Group NHS Foundation Trust. Mike, who's been busy typing away and answering a lot of your questions. Mike Waters, who's Virtual Wards Operational Lead at Norfolk and Norwich University Hospitals NHS Foundation Trust. It's a mouthful, Mike. And Sophie is here, of course, Contract Manager from Baywater Healthcare, and Jenny Hall, who's Commercial and Clinical Director at Baywater Healthcare. So what I would say to the panel, probably just jump in a little bit as we're going through if there's something you wanted to add to it, and sort of the camera will track you through. But remember to take obviously your mute off as we go through that. Oh, and Heinderu is also here. Good to see you, because I know you've attracting clinics, so we've got you all here, so that's good. Can we start, Mike? Can I start with you on this one, because I'm sort of thinking of those who haven't had a chance to sort of speak live. When we're thinking about barriers, there are obviously some barriers that when you're setting up a virtual clinic that you anticipate, and then there are those that sort of emerged as you went along. Can you just sort of go through some of the sort of rate those, some of the biggest barriers you found, those that you anticipated at the beginning that you were able to mitigate, and those that sort of came along and you thought, oh, never thought of that. So kind of exploring the barriers.
Yes, certainly. So I think the barriers that we thought of at the beginning was going to be whether patients will cope with technology in the home. Obviously, we're in Norfolk, which is a real backwater technology-wise. Would the signal work, that sort of thing? So when we were looking for a system that would work, we went to Current Health, who offered us a system to do mobile connection, Wi-Fi connection, that sort of thing. So actually, that barrier was a really easy one to overcome. We were concerned about how simple it would be to set up, because obviously we're asking people to set up a system in their own home. And I know if I said that to my mum, her first thing would be panic. I'm not going to manage that. So it's a case of how can we make this as simple as possible. And then barriers, again, were much, much easier to overcome than we thought they would be. People were embracing the technology, and it surprises me. You'll get a 92-year-old gentleman who's like frail as anything, and he gets his iPhone out and starts fiddling around and playing with it. And the way we've set it up, I can't take any credit for that, is really, really simple. It's done with animations showing them where to put whatever, and it's the simplest thing in the world to do. So that surprised us in that we didn't have that much of a barrier from that point of view. The biggest barrier we've come across, which is surprising, is our medical colleagues not wanting to take the risk of patients going on the virtual ward. So it's actually getting them engaged, proving to them that we are a safe option, that these patients are monitored 24 hours a day. It's also getting over that thought that they would get more work from doing this. So their argument is, I've got 40 patients on my physical ward. If I put another 10 on the virtual ward, that's going to make more work for me. So the way we've overcome with that is pure communication. So it's going along to government's meetings, explaining the situation. All of our patients, I can only speak from a Norfolk and Norwich point of view, would otherwise be in an acute hospital bed. So the way we've managed that is by saying to them, yes, you've got your 40 patients on your ward, but the other 10 patients are on the virtual ward would otherwise be outliers on different wards. So you'd have to do your ward round, then you'd have to visit 5 other different wards to see your patients on them wards. We can overcome that for you by putting them in one place. So you do your physical ward round, then move on to your virtual ward round, much quicker and easier. And it's taken a long time. I mean, we're coming up for 2 years old now, and we've now finally got every single speciality on board. And the ones that were really slow to take up are now the ones that are getting the most referrals from. But the key is communication. We've done a lot of work visiting every ward, visiting every team, explaining to them how we work. So I think the biggest barrier that we've had to overcome is people's fear, really, more, and that's more from a professional level rather than a patient level.
Yeah, because it is about change, isn't it? This is sort of a second order change. It's a huge change for people, and you always get people resisting because they're moving outside of their comfort zone. I mean, Karen, did you want to come in on that one? Anything resonate with you there in terms of change and the barriers?
Absolutely. I mean, I think from a paediatric perspective, which is obviously what our virtual ward is, that we were one of the the front runners for that, because there were different sort of versions of hospital at home and community ward outreach teams and things like that, but the actual virtual ward in the sort of concept that we talked about here hasn't really been done. So we ourselves also, I would have to say, our biggest challenge has been taking our medical colleagues along with us, particularly given that the children cohort, as I'm sure you all know, they do get sick really quickly, but they do get better really quickly as well. So in terms of the nervousness that people have, in terms of, you know, that child could deteriorate at a much quicker rate than we would anticipate an adult deteriorate, and that created a lot of nervousness. And we've spoken a lot to colleagues in the ICS and across the country about paediatric virtual ward, and that is the thing that constantly comes up, is that nervousness about the rapid deterioration. I think for us at Dudley, what was the positive was that we had a team that were quite well embedded in terms of community outreach, and we utilised them as part of the team to launch virtual ward. So our clinical team had quite a lot of confidence in them as a group of clinical decision makers, and they got quite a shared responsibility already in terms of that community and acute hospital trust working, and I think that really helped us as well. And you're absolutely right, we just communicate all the time, and actually now some of the people that were our most cautious are the people that are constantly asking us, have we got any more vacancy on the virtual ward? Can you take this child? I've got a queue now of children that I want to put on the virtual ward. So absolutely resonates, and communication is definitely the key of trying to reduce that anxiety that we naturally have.
I'm wondering whether, I'll just stick with you, Karen, then I'll bring everybody in. And Mike, you might want to comment on this as well. Are there, when you segment your patients, are the patients that take to it like a duck to water? Are there a group who don't but can be moved into a situation where, with support, and how much support do you give, you can get them to that place that you need them to? And are there a proportion of patients who, whatever you do, don't want it, will never take to that? Karen, do you want to come on that one, and then I'll get Mike to dive in on that one? So sort of the impossible patients, who struggle with it, and those in the middle who you can move.
Yeah, so really we haven't had our impossible patients have essentially been, obviously from a paediatric perspective, there's been two cohorts that I can think of. One would be the safeguarding group of children that obviously it's not the right decision to propose virtual ward, and the other would be some of the language difficulties, because the platform that we use isn't necessarily supportive of different languages. So that's something that we're working on now in terms of trying to expand that. Because our parents tend to be quite young, they're quite savvy, they're quite digital savvy, so I have to say we haven't really had a problem in terms of orientating them to the use of the equipment, because it's simplistic. If you can use a smartphone and you can use an iPad, generally speaking, you can use the monitoring equipment that we provide. So what we started with was a step down model. We're now moving to an admission avoidance model. So obviously in terms of that clinical decision making, there is still some caution in terms of the children that we would push forward to virtual ward. So but I wouldn't describe them as the impossible group. I would just say that we're still sort of making sure that the decision making is safe.
Mike, did you want to come in on that one, the type of patient, and whether there is an ability to move a certain proportion of them who were resistant to start with, and those who it's not going to work for?
Yeah, I mean, we're in the position where all of our patients have to agree to coming onto the virtual ward from the start. So we see the patients, we talk the patients through our system. We get very few, to be fair, that are resistant to it. But obviously, if they turn around and say, I don't feel comfortable, I don't want to be on the virtual ward, they don't come on the virtual ward, they stay within the hospital environment. And it's also made quite clear in our consent form that if at any time they don't feel comfortable being at home, want to come back, then they can come back. So impossible patients, I think we've only ever had bearing in mind we've gone through something like 10,000 patients now. I think off the top of my head, I can only think of about 10 or 20 that do not want to come on because they don't feel they'll manage it. Patients that absolutely love it, and it's probably not surprising, do tend to be the younger patients. I had one chap who's a scaffolder came to me, it's giving me high fives saying this is absolutely brilliant. I'm blown away by it. It's technology, you know, it's fantastic. So again, I think the key point in all of it is communication. We're very much the same as Karen's, that we started off initially as discharge, facilitating an earlier discharge. We're now getting into admission avoidance, which is going to be probably slightly more challenging because at the moment we've got the benefits of them physically being in a hospital, so we can go and spend a lot of time with them, talking them through. Admission avoidance is going to be slightly more of a challenging environment that we're moving into.
I mean, Jenny, do you want to come in there, because you've been busy tapping away and answering people's questions? The whole concept of barriers, what you found are barriers that you anticipated, barriers that came along. Does what Karen and Mike are talking about resonate? Is there any more you can add as we break down into, you know, some of the barriers that needed to be overcome?
I think for us it was the same sort of barriers. We found something we didn't anticipate was the onboarding and discharging of patients, the amount of time that actually took and how intensive that could be with some patients. You know, as you're saying, there's some patients that are more used to technology and using their own technology that were quite quick to pick it up and very open to it, and others where we had to spend more time and go out and do some repeat training with them. So it was around, a lot of the administration time was probably longer than we anticipated to start with. I think that's probably fair, Sophie and Hein, from the service. We had to adapt that quite quickly. We found actually patients were far more receptive to coming on and using if they use their own devices. So our platform is very much to integrate with existing. So if a patient has their own tablet or their own phone or technology, they can just use that. And I think patients were far more comfortable with that than having a new piece of kit. I don't know if there's kind of the old, you know, Android and Apple thing. You know, if you're an Apple person, you struggle with Android, even if you use technology. So that was definitely an area we focus on, is around patients utilising what they already have and what they're familiar with. That makes a big difference.
I mean, Sophie, do you want to come in on, while we're just circulating around, circling barriers, any more thoughts on barriers from your own perspective?
I think, as we touched on from a provider's point of view, so making sure we worked very closely with Hein and the team over at Gloucestershire to make sure that the specification was built around exactly what the clinical team were looking for. So with regards to service level agreements, to regards to technology, technicians going out to visit patients in their own homes. I've just answered a question in the Q&A about having a hospital bag, so doing a hospital discharge. So could the hospital team have their own kit there and bits to give out to patients if needs be? I think it wasn't necessarily a barrier, but it was something that, as we've been in the market for telehealth and sort of virtual wards for over 12 years now, we already knew the concept of that, but it was something new that we brought to the table to Gloucestershire to make sure that we ironed all those out before the service started. So the implementation of the service obviously took a lot less time than what we would have anticipated if we didn't have that kind of knowledge.
Can we look a little bit at lessons learned? I suppose the question that's interesting me for any of you, has it gone wrong unexpectedly? Because those who are sceptical or cynical, I know I've been around a long time, there are certain people who look for it. Well, there you are. This is what happens when you change, you know. Has it gone wrong? And how do you put in place a structure for lessons learned? I mean, what's in place so that you can review, so that you can create a culture that is about a learning culture rather than one of a punitive culture?
Richard, can I just come in there? Yeah, it's a great question, because things go wrong all the time, don't they, and in daily practice. And I think that psychological safety, which I think we had to work to achieve, because we never met each other. We were kind of thrust together remotely, and we were trying to like build the aeroplane whilst we were flying it. I'm sure everyone else on the call will say the same things. And actually, you're reliant on people feeding back to you, going, what about this? What about that? Sophie's mentioned the pulse oximeters is not arriving because of the postal issues, but you need to be talking all the time whilst you're setting up this service. Now, I mean, I've moved on, but I don't think we talk nearly as often as we did because it's a mature service up and running. Most of the things have been thought through, but when you're setting it up and trying to learn how to work together, in a way, the patients are the easy bit, because most of the patients I see want to stay at home, right? The difficulty is, you've identified these, often the doctors, but referring in, but then the real thing is learning how to work together in this new way, and that requires a sort of different forgiving type of leadership. But look where we are now, Sophie. I mean, it's fantastic what you guys and us have achieved.
I mean, the question is, this is all about change management, isn't it? And change produces resistance and difficulties. There any tips on the change process? Because we've heard communication, but I know all of you will have gone through some kind of change structure, whether you did a force field analysis to look at all your barriers to doing this, whether you got key people on board, who do you engage with, who are the key people who can move it, and you can put in your pocket who are going to be your champions, etc. I mean, Mike, I'll start with you again. I mean, the change process itself, can you make it explicit how that process works through some things that you did, however informal or formal that process was? It is about change.
Yeah, I mean, when the ward first started, I've only been with the virtual ward for a year, but how we've managed it since then is we have employed consultant champions for each speciality who will champion our calls. We also do daily ward visits. We have ward of the week where we go there and we actually spend a week on that ward, showing the staff, that's the medical staff, nursing staff, OTs, physios, exactly what we can do. So I know you said it's communication. I can't say it now. Communication, but that is, that's the only thing that we can do. We highlight our successes. So I make sure that we have a daily communications email, and I make sure that we're on that at least twice a week. People are probably fed up with us now, but I just like to celebrate our successes. If we've got an area that's not referring many, we go to them with a specific patient that's worked really well and say, look, this is what happened when you gave us this patient. What's the barrier? What's stopping you from referring more? So we had, for example, an OPM consultant who stopped referring. When I went and spoke to him and said, why not referring? He says, because with OPM patients specifically, the chances are they may deteriorate. And what happened was, one deteriorated, we called an ambulance to get them back because the ambulance trust felt that the patient was being monitored, so it wasn't a priority. It took them 14 hours to come back in the hospital. So he said, I'm not prepared to take that risk. So from that point of view, we then looked into how we could use St John Ambulance's rapid response volunteers. And so we utilise them now. So we've learned from what he's come to us and said this was an issue. We've learned how we can overcome that. So we can go to him and say, we are confident we can get your patient in much quicker if you will refer the patient. It's also it's making it clear that it's a bit of a vicious circle, because the more people he can discharge onto us frees up more beds to enable us to drop the ambulances off. So it's making it quite clear that it might take a bit of a hit, but we can overcome these issues. So it's showing that we can make a difference and that we can make changes to help them.
Any other comments from the team there on particularly that change management process? If people are doing things to prevent reinventing the wheel, the change process that needs to go through, is there anything on that change process that needs to be there to make it more successful?
So one of the things that we made sure that we did from an early onset, we very much took a PDSA type of approach, whereby we were waiting for things to, we were looking, we were planning, we were waiting for things that didn't work, and we were quite happy to pause if we felt that there was something that needed an immediate action. We didn't see that as a failure. We saw that as a really positive thing, because it gave us the opportunity to make the change and make it in real time so that it made an impact there and then. I think the other thing that we made sure that we we did a rapid evaluation study quite quickly. So after about 4 months, we did a rapid evaluation study that we looked at. We went out, we spoke to parents, we spoke to staff members, we did a review of the service just to have that opportunity to sort of say, you know, is this giving us the outcomes that we expected it to? Is this really of benefit? Because obviously, you know, in our enthusiasm, we're always going to say, of course, it's absolutely of benefit. So we just wanted to make sure that we've got that evidence to support that. So we did that. And the same as Mike, really, you know, actually making sure that we gave feedback and we gave the good news stories, you know, the things that made people go, oh, actually, that's positive, that worked. And we can see why, you know, that is sort of a reason why that we need this virtual ward. So yeah, lots of similar things, but I think there was a couple of things that we took a little bit more of a formal process with.
Hein, do you want to come in on that one, because you were sort of saying about small steps?
Yeah, no, absolutely. I'm so glad to hear PDSAs being mentioned. I think if you take that quality improvement approach, start with one, because yeah, I mean, I'm doing this for NHS England now around the region, and people are thinking, oh, yeah, we've got to set up, you know, 100 beds or virtual beds. And you think, no, start with a dummy patient. It's not actually about the 100 beds. It's about your little team getting confident and working together. And the only way I think you can do that is with those PDSA cycles that Karen said. But, you know, it doesn't have to take 6 months or a year. I mean, you can do a lot of stuff quickly, but just start with 1, 2, and keep PDSAing, reflecting. And then you'll get to a point where you can start with real patients, but, you know, go where patients are easier, where it's safer, so you can learn how to do it all yourself. And, you know, if we had this conversation, I'm sure in a year or two, and, you know, Michael, they've got, sounds like a really good, mature service that everyone knows what they're doing. And we, you know, we can learn from each other. That's the other bit, which is what we did with COVID. But a lot of this is, the new NHS is about sharing and learning from each other, not competing. So all your lessons learned, well, why do you have to learn the same lessons we did? We'll just tell you about them, and then you can, you know, we can all improve together. So I think that cultural bit is also really important.
I mean, how do you share best practice? We've got a seminar today, a webinar today. Is there any, where do you go to learn what's happening elsewhere? Are the forums, are there publications and so forth? Publications tend to sort of take time to come out, don't they? People kind of also like things that are a little more immediate. I wondered where you do go to stop reinventing the wheel.
I mean, we've got communities of practice where we invite, so we had one yesterday, this is for NHS England. You have a speaker in showing what they're doing. We had someone called Kath Moynihan, who is a respiratory consultant in Hartlepool, and she was just unbelievably amazing. And what they'd done over 6 or 7 years, and all of the challenges and barriers we come up against, and then, you know, she's gone through them, and, you know, it's just really powerful having those patient stories, but also clinician stories. And then, you know, it kind of, because everyone's a bit beaten down, aren't they? It's been really hard work, really stressful. Loads of our colleagues have been all sick. The thought of trying to do something new on top of everything else, it's hard, isn't it? And so that sort of inspiring leadership, and as Karen was saying, you know, actually when something goes, I don't mean something going wrong when a patient issue, but when something on the service doesn't go wrong, actually the whole point of QI is you learn from that. And if you don't try some stuff out, you'll never move forward. So actually, you know, things going wrong needs to be expected in a way, doesn't it, Karen?
Absolutely. That was the view that we took, that we expect something to go wrong, but let's make it, you know, if we're doing the little steps, then it's not going to be catastrophic. It's going to be something that we can manage.
Did anybody want to mention or comment on the cost-effective nature? That's something we haven't particularly looked at greatly. The cost-effective nature is just a question that's popped up in the box. Cost-effective nature of the services against the current district nursing and care service currently available. Go on, Mike.
Yeah, sorry, we did a review probably about a year ago now, and for the acute virtual ward that we run, it is the third of a price of staying in a hospital bed overnight. is how we worked it out. And we get all the same with the Q&As. We use the NHS Futures website, and there's a big section on there on virtual wards, and all of our documentation, all of our audits, all of our operating procedures, etc., is on that website. We share everything. We're happy to share everything, so it's all on there if anyone needs anything.
But Richard, I think it's just careful of the audience in a way, because I think to clinicians, if you went, oh, it's going to save loads of money, as Karen or Michael said, I mean, actually, you know, if you're thinking, well, this is going to double my workload, or something goes wrong, I'm going to be in front of the coroner, you don't actually care about the money that much. And I think the money is important. I'd think of it more as a value rather than a total thing about money. And I mean, the thing that's going to help, you know, is actually patient flow through our systems. So actually, does everyone who's in the ambulance queue need to be there? Does everyone who's, you know, on a trolley or sitting in ED need to be there? And actually, I think the money, of course it's important, but actually the patient experience, the clinician experience, how the system flows. And I think when you not you, but when one uses those terms and explains it in that language, I think you get much more buy-in and traction, and the money will sort itself out, I think. What do you, well, I don't know what other people think.
Yeah, I think when we were thinking about virtual ward, obviously it came at a point where we were RSV planning, surge planning, and there was a really sort of anticipation that it was going to be overwhelming for paediatric services, and that's what was the driver for our paediatric virtual ward as part of our ICB. However, I have to say, in terms of patient experience, patient flow, I actually don't know how we would have managed this winter to date if we hadn't have had those additional 12 virtual ward beds, which have allowed us to continue to flow the urgent treatment centre children, the children that are coming from ED, that are coming from the GP referrals, because obviously it's been a tsunami like it has been for everywhere else, and really our occupancy of virtual ward has exceeded what we actually thought we were going to need because of you know the confidence has increased. But yeah, so it's been all about patient flow and the patient experience. I have to say the feedback has been overwhelming from a patient experience perspective from parents and carers.
I'm just picking up on that. What is the sort of evidence base behind virtual wards? Is there a lot published? Is there a lot more coming out now, or is it much more local service evaluations that are going on? I'm wondering what the literature, you know, what the literature is out there, what you found.
So there's not a lot for paediatrics. There's not a lot about little people. So it's obviously most of the models are around adults. So there was very little for us to pull on.
Yeah, again, I think from my perspective, there is very little, and I think the issue with that is around the difference in the virtual wards across the country. You know, everyone runs a virtual ward differently. We're an acute virtual ward where they remain inpatients. That's we're 24 hours a day. That's a very, very rare service. So yeah, there's not a lot at the moment. I think more will come going forward, but I think this is going to be the main stumbling block for people that are starting virtual wards now. It's which model do they use, community virtual ward or an acute virtual ward? How do we merge the two together? That's going to be the next big change.
Yeah, I agree with Mike and what Mike said there. There's not very much for people to look at or to follow with regards to case studies, and when you're looking at what kind of virtual ward do I set up? Is it acute? Is it primary care? Is it just for 7 days monitoring of a patient coming out for wound care management? It is very, very difficult at the moment, and I think again it goes back to this whole communication, communicating with each other, different teams, different virtual wards that are already live to get their experiences, having a look just to see what case studies are online or what you can get your hands on, and these webinars are absolutely brilliant because obviously we can all showcase what we've done and what we're achieving and provide our support to other people as well.
It's almost an opportunity for team working with the university sector as well. They're always looking for research that can be applied. This is a perfect opportunity where obviously individually we can't all do our own research. It's a huge amount of work to do, but working, perhaps, I'm just sort of throwing ideas out, having come from the university sector, they're always looking for important pieces of research that you can work collaboratively, and therefore the workload is less on each individual person. I mean, Jenny, did you want to come in there on measuring effectiveness on those virtual wards?
Yeah, I mean, as Sophie said, I think because they're relatively new, but they're not new. It's around, having the outcome data and the effectiveness. And I know that, Mike and Karen, from experience of running it, you could probably reel off a long list of outcomes and things. I think just going back to some of the stuff that I said a bit earlier around people that try and sort of set up the virtual wards, one of the things that we've seen, I know Sophie touched on it, was people trying to do too much all at the same time. So we've been working with lots of commissioners and engaging with lots of people trying to look at how they set services up, and everyone's trying to do too much at the same time because they have this remit that we have to have a virtual ward. And so if we get stuff through, doesn't it say that we want to cover frailty, diabetes, heart disease, falls, maybe some social care, and we want, and the size of what they're looking for and the scope they want to cover is too vast for one service. So, if anybody is out there that's looking at how they set up and how they start, I know Hein talked around, starting small, is maybe just choose one condition or one area that you want to focus on and start on that on a small scale and build. And, I think people get lost in the virtual ward can cover everything and anything, and it can eventually, but that's not your starting point. And that's, I think, in the last 6 months, with the focus from the NHS on making virtual wards a priority, everything we're seeing is trying to chuck everything at it in one go, and it's just not achievable, which means that it kind of fails before it even starts, because they can't even scope the service what they want and how they want it to look, let alone actually start working with a provider or commission. So I think that's probably a key thing, if anybody that's on here that's thinking about doing it, is look at how you set it up.
Mike, do you want to come in there?
Yeah, can I come in? I 100% agree, and I think this is my one concern. Sorry to end on this point, but my one concern going forward is that we're being asked to do too much too soon. What I don't want virtual wards to become personally is just another ward. We are special. It is the future, so we've got to have the foundations right first. So I 100% agree. Start small, celebrate your successes, learn from your mistakes, and move forward from there. My one concern, as I say, every time I turn on the news, it's virtual wards are going to save the NHS, etc., and have this done by March 2023. That worries me, to be honest. We need to get the foundations in first and then build from there. So I'd advise anyone to start small and go up.
I'm just looking at some of the questions as we head to the end. Somebody's asked, have you had any deaths within the virtual ward, or I suppose we could say major deterioration of patients, and how are those managed?
So we have on the Norfolk and Norwich one, again, we are slightly different because all our patients are still considered inpatients. The death we had was an expected death, so we do have palliative patients on our ward as part of our remit is a palliative pathway. So again, they're managed in the usual way. If we were to have an unexpected death, then it would be the case that the patient would be brought back to our hospital mortuary, usually under police guard, and the usual procedures followed from there as if they were unexpected death anyway.
Don't know if anybody wants to add to that. Karen.
We have a full debrief afterwards as well for all our staff, because obviously we get to know our patients quite well. So
from a paediatric perspective, on our virtual ward, we've had very minimal numbers of bounce back into the acute trust from the children that have been admitted to virtual ward, and probably just one that I can think of. We've had about 350 children on the virtual ward up to now over the 11 months, and we've only had one that I can think of that was an acute deterioration that needed readmission out of all those, and it was managed entirely appropriately in terms of the deterioration was picked up by the team and safety netted back in through the designated pathway. So it went as we expected it to.
Just the last question. What skills are you looking for in staff that join the virtual ward? Is there certain qualities that you think staff particularly need when they join the virtual ward?
I think good old-fashioned nursing skills, good communication. I think if you ask the staff that work for the virtual ward, it's a revelation. They absolutely love it. I listen to the calls on every day. It's a different type of nursing. You need to know about a lot of subjects, a broad range of subjects. You need to be able to work on your own, because often you're the person that's making the decision. Do I need to bring this patient back in? Do I need to escalate this? Do I need to escalate that? But most of all, the satisfaction that the nurses get, you're literally, from our point of view, we're talking one-to-one with a patient, which doesn't happen on the wards anymore. You've got no interruption, so you get to know that. You saw in the video earlier on, that's a video from Norfolk and Norwich. You get to know your patients. They tell you about who's coming around for dinner, who's coming around for tea, you know, and it's so lovely. You really get to know the patients. And I'm an old nurse, so it's sort of like going back to old-fashioned nursing to a certain extent, where you get to know your patients, you do things with the patients, you're interacting with the patients, rather than, you know, sometimes on the ward it's got to the stage where you're given an IV, moving on to the next one, given an IV, and they're a number, not a name. So I think it's definitely communication skills, empathy, and professionalism, because you need to know your stuff as well.
And I would agree. One of our nurses was asked, why do you want to do that? You're just stuck by a computer. And her reply was, absolutely not. I'm using all of my clinical assessment skills, probably more than I've done ever, because I know that I'm responsible for that patient and for getting it right for that child. So yes, they have to have those digital skills, but actually the nursing skills are what's absolutely key.
Okay, I'm going to wind things down, folks. First of all, thank you to all four of you for keeping that bubbling along very well. And I've tried to answer, folks, as many of your questions as I can, but I know all four of our panelists and those on today are more than happy to answer questions if you want to drop them an email, because that is the culture that we're talking about, sharing and not reinventing the wheel. So thank you very much for that indeed. I hope you've enjoyed the RCNI webinar. We tried to get through as much as we can. We'll email everybody's attendance certificate to them. If you don't receive it by the end of the week, can you contact events or event support at rcni.com, and Rosie and the team will make sure that you get that. But can I say thank you very much? It's been enlightening for me, and I've been in it 34 years, and just as Mike's sort of implying there, there's something new every day coming along. So thank you very much, and enjoy the rest of the day, everybody. Thank you very much.